1 o'clock.
This journey has been long, and it hasn't been easy. But now is not the time to let your guard down, because grandparents still need you. Teachers need you. Nurses need you, and their babies still need you. Traditions need you. Your communities need you. Wear a mask. Maintain social distance. Be safe. You're ready for this to be over? We are too. And how we get there is by doing the right thing. Now, together.
Good afternoon, and welcome to today's Michigan Medicine Well Aware presentation. I'm Dr. Preeti Malani, the University of Michigan's Chief Health Officer and a professor of medicine in the Division of Infectious Diseases, and a returning panelist to Well Aware. Now, this week marks the one-year anniversary of Michigan Medicine admitting our first patients with COVID-19. And in fact, yesterday was the anniversary of the first confirmed cases in our state. And for all of us at Michigan Medicine, it's been a time to reflect, process what this year has been like, looking back on everything we've learned, what's happened to our community, good and the bad, and to look ahead to the next phase of the pandemic, the arrival of vaccines, and the hopeful return of so many of the day-to-day things we hold dear, but also concerns about new variants and the other many health issues that have gotten worse during the pandemic. And we're all rethinking how we can provide care to improve the health equity disparities issues that we all saw and became even more apparent in the context of COVID. So just a couple housekeeping issues. Thank you to everyone who submitted a question in advance. We will work to answer as many of those questions throughout the presentations and certainly during the question and answer period. And as usual, we'll also be accepting questions during the Q&A portion of today's presentation for anyone who's joining us live through Zoom. So please use the Q&A feature to ask your questions, and we'll get to as many as possible. I'm joined today by two of my favorite people, two great leaders. We have Dr. David Brown, who is the Associate Vice President and Associate Dean for Health, Equity, and Inclusion. He's also an Associate Professor of Otolaryngology, Head and Neck Surgery. And Dr. Brown will focus some of his comments on health disparities and some of the things we've learned. And also joined by Dr. Laraine Washer, who is Michigan Medicine's Director of Infection Prevention and Epidemiology, and an Associate Professor of Medicine in the Division of Infectious Diseases. And she will talk to us about a lot of things, including the new vaccines and variants looking ahead. I've had the pleasure of knowing both of them for nearly 25 years, and they're just wonderful human beings, and they've been such great leaders throughout this past year, especially. And a year ago, we were just at the beginning of the U.S. pandemic. And, and as I think back, even seeing what was happening around the world, it didn't register for me as something that could really even happen here. I was rounding on infectious diseases last March, beginning of March, as our first patients began arriving. And I was also going back and forth to Central Campus with my role as Chief Health Officer. We had hours and hours of intense meetings trying to figure out what we should be doing. We didn't even have any cases in Michigan yet, but our students had returned from spring break. And, it felt like things were going to get bad quickly, but we weren't sure what was going to happen. And it all feels obvious now, but it really wasn't then. And over the course of a few days, everything changed. And the images that we just saw on those videos and the video, leaves me with a lot of different emotions. Certainly grief and sadness, fear, but also immense pride and so much love. And over the course of those early weeks, the hospital transformed into a place that, for me, frankly, it felt lonely. There weren't the usual crowds in the hallways. We didn't laugh. There wasn't the same joy that I was used to feeling. For me, I'll be honest, it was scary. I wasn't really sure what was going to happen. I was worried about my own safety, that of my colleagues, my family, my friends, my community. But I also felt so much gratitude. I heard a lot of thank yous. I heard a lot of, can I help you? I loved being part of the team at Michigan Medicine. The nurses, the respiratory therapists, the pharmacists, the technicians, the transporters, the doctors, all the various support services, everyone who did their part and kept the trains moving. And so many people in the community who said, what can I do to help? You brought us food, you brought us masks, you brought us PPE, you made face shields, local dentists, school clinics. They emptied out their shelves and said, here, take these. You need them more than we do. You washed our kids, you walked our dogs, you sent texts and emails, you wrote inspiring messages in the sidewalks. And most importantly, you stayed home and helped Michigan crush the curve. Rethinking and refitting every aspect of your life is complicated. And at the health system, we had always prepared for things like this. People like Dr. Washer had developed detailed plans for this type of event. But I don't think any of us could really have imagined the kind of questions that we were asking ourselves. And this is a time where creativity and collaboration was really on display. For example, when we didn't have enough N95 masks, our colleagues in engineering figured out how to reprocess ones and even print ones with 3D printing. And they were able to do that and share that information with the world. Now, all of you will remember that Michigan was hit hard and it was hit early, and the epidemiologic models suggested that we were going to run out of space in the hospital within a few weeks. And we even began planning the groundwork for a large hospital, a field hospital on athletic campuses, on the athletic campus. Nurses and doctors came out of retirement. They raised their hands and said, I'll help. Others were redeployed to the ICUs. Some of my colleagues in primary care came and rounded on general medicine. It was the first time in the hospital in years for them. And slowly things got better. We learned how effective masks were to prevent transmission. Testing became faster, became more available, treatment got better, and now, truly remarkable, 3 safe and highly effective vaccines under emergency use authorization, almost 100 million doses given in the United States. 1 in 4 US adults has gotten at least 1 dose vaccine. there's still a long road ahead. You know, I think for me, the big lessons that I learned this past year are flexibility. Things change very quickly, following the science and data, trying to communicate it clearly, and also understanding that people around you are often in distress. So kindness and patience goes a long way. And with that, I'm going to hand it over to Dr. David Brown.
Thank you, Dr. Malani. I'm David Brown, the Associate Dean and the Associate Vice President for Health Equity and Inclusion. I'm excited to be here with you today. Looking back over the past year, one of the things that sticks out to me the most is how the pandemic highlighted our longstanding national issue with healthcare disparities. COVID did not bring about these disparities, but brought them to the forefront in a major way. Black, Indigenous, and people of color at twice the rate of white individuals. Let's see, we're on our correct slide. Can you go to the next slide, please? Thank you. Many of the disparities are rooted in the poor social determinants of health, comorbidities, insurance coverage issues, having a frontline service job, poorer housing conditions, and others. There are also disparities realized by those of lower socioeconomic status, those who live in rural areas, and those without access to healthcare and technology. In addition to that, there are healthcare disparities for individuals with disabilities who suffer from inaccess to health information, biases against them, poor social determinants of health, and the lack of disability-friendly guidelines for emergency preparedness. And the intersectionality of multiple marginalized identities increases one's risk for disparities. Next slide, please. For minority communities, the COVID-19 pandemic crisis was compounded by a public health crisis that existed for centuries prior to the coronavirus, and that is systemic racism. Systemic racism is a public health crisis that not until the death of George Floyd and other Black individuals did our nation begin discussing the ramifications of systemic racism. Our healthcare system began transitioning our conversation from how bias impacts healthcare disparities to how racism impacts healthcare disparities, because we are now becoming more comfortable with speaking out against racism. At Michigan Medicine, we began evaluating the policies, practices, and procedures that would help us be a more anti-racist academic medical center. Next slide, please. Our white coats for Black Lives medical students were instrumental in outlining the issues that exist within Michigan Medicine and medicine in general, and challenged us all to do better. Thoughtful concerns combined with a Michigan Medicine-wide survey for our racial discrimination and social unrest town hall, where we asked the question, what actions can we take to be more anti-racist? This yielded these 6 major themes. We then developed an anti-racism oversight committee, which we call AROC, and the plans of AROC have been finalized and are moving forward toward their implementation. Within the action plans are changes in the medical education to include social justice, critical race theory, and community-based engagements. Next slide, please. We started on the journey to anti-racism and health disparities in August of 2019, actually prior to COVID. The Office for Health Equity and Inclusion had our first Health Equity Leadership Weekend and invited all the M4s from our medical school, as well as M4s from around the country, to participate in a weekend-long forum on becoming a change agent in health equity. We invited a national leader, Dr. Kamara Jones, to be our keynote speaker and address the impacts of racism on the health and well-being. In 2020, our program was virtual because of COVID, and we had almost 400 participants and covered anti-racism as well as gender inequities and gender disparities. We're looking forward to our program this August. We also developed a 1-year curriculum to teach healthcare disparities to our residents. Next slide, please. Our curriculum teaches the learners about the social determinants of health, anti-racism, and quality improvement techniques to evaluate the outcomes of diseases and treatments by race, ethnicity, and primary language, as well as sexual orientation and gender identity data. We also teach them about cultural humility, which is a lifelong process of self-reflection and self-critique, whereby the individual not only learns about another's culture, but one starts with an examination of his or her own beliefs and cultural identities. It's rooted in these three principles below, which are important for equitable care. Next slide, please. Cultural humility can also help us grow in our understanding of each individual's diversity while decreasing the power imbalance by encouraging us to realize our own power, privilege, and prejudices. And when we shift the power to the patient, they're the expert on their own identity and culture. And this can increase the quality of interactions and the sense of partnership and trust with patients, which are all important for high quality care and equitable care. When patients trust us and feel heard, they're more likely to give us important information and more likely to comply with the treatment plan. Next slide, please. Balancing power, privilege, and prejudice might have been impactful for the outcome of our own Dr. Susan Moore, a 2002 graduate of our medical school. Can you please play the video?
If I was white, I wouldn't have to go through that. At that time, I'd only received 2 treatments of the remdesivir. He said, you don't need it. You're not even short of breath. I said, yes, I am. He further stated, you should just go home right now. And I don't feel comfortable giving you any more narcotics. I was in so much pain from my neck. My neck hurt so bad. He made me feel like I was a drug addict. And he knew I was a physician. This is how Black people get killed. When you send them home and they don't know how to fight for themselves.
My next and last slide. This video shows that even a well-educated physician does not have the social capital to advocate for herself as a Black woman. Since Dr. Moore's death hit close to home for many of us as a graduate of our medical school, many leaders within the healthcare system are thinking about ways of developing a health equity consult service. We want to mitigate the inequities in real time. In addition to providing more equitable healthcare to our patients, we hope that this educates our faculty, staff, and learners, including medical students, as well as inform our policies, practices, and procedures that will lead to more equitable healthcare. I'd like to now welcome Dr. Washer.
Okay, good afternoon, and thank you, Dr. Brown, and especially thank you for that very moving and tragic video highlighting one of our medical school graduates' experience and unfortunately death due to COVID. And looking back on this last year, our collective experiences of the COVID pandemic have truly been unprecedented, and they are sure to define our times. The toll of the pandemic to this point has been extreme. Next slide. This has included an estimated 117 million cases and 2.6 million deaths globally. In the US, more than 29 million cases and more than 500,000 or 500,000 deaths in the United States. To put this into perspective, this equates to more than the number of Americans who died in World War II, and it's nearing the 675,000 US citizens who died in the 1918 influenza pandemic. It is orders of magnitude above the average of 12,000 to 35,000 annual flu deaths. And as we just heard, each of these deaths represents a personal story and a personal loss that will last even after the pandemic abates. As highlighted by Dr. Brown, we know that racial, ethnic minorities, people living in poverty, elderly and nursing facilities, and other groups have been disadvantaged in regards to the COVID-19 disease burden and severity. And all of us have seen the large-scale impact on our personal lives and on businesses and education. The good news is that cases, hospitalizations, and death are declining, but progress has slowed nationally recently, and some cities are backsliding. However much we want it to be over, the pandemic is not yet over. There are still over 50,000 new cases daily in the United States, with up to 2,000 daily deaths. And there is risk for increases in these numbers with lifting of masking and social distancing restrictions in some locales. Next slide, please. But there is really great reason for optimism with the COVID vaccine as a reliable exit strategy leading our way out of the pandemic. This remarkable and rapid development and testing of multiple vaccine platforms is possible and only possible due to decades of investment in vaccine science research. It is amazing to me and to many of us who study infectious diseases that we have 3 COVID vaccines that are available in the United States, and all of them have been shown to be 100% effective at preventing hospitalization and death due to COVID in clinical trials. The 3 vaccines are listed here. There's the Pfizer-BioNTech vaccine. This is an mRNA vaccine. It's given by 2 doses. It's approved for those 16 years and older. There's a second mRNA vaccine made by Moderna. This is also 2 doses and is approved for those 18 years and older. And then lastly, there's the newly authorized Johnson & Johnson Janssen vaccine, which in contrast to the others is a viral vector-based vaccine that is given in 1 dose and is approved for those who are 18 years old and over. All of these are very effective at preventing the most important outcomes, that of hospitalization and death. And we really encourage anyone who is eligible for a vaccine to get the first vaccine that they're offered. The vaccine implementation strategy has been difficult. It has required a lot of logistics, and it has been devised to have a phased implementation plan to maximize the benefits, minimize the harms, at the same time mitigating health inequities that we've just heard about. We're making great progress. The United States is administering an average of 2 million vaccine doses a day. And as of March 8th, 17% of the US population has had at least 1 dose of vaccine, and almost 10% have been fully vaccinated. Next slide. There's been a lot of talk and concern about SARS-CoV-2 variants. And I want to suggest that really there's still great optimism, even though there's some additional challenges being introduced with the COVID vaccines. I remain very optimistic that public health and vaccination strategies will ultimately be successful. There are multiple SARS-CoV-2 variants circulating globally. You may have heard of some of them. There is the UK variant, which is known by scientists as the B.1.1.7 variant. And in some cities in the United States, this is accounting for up to 20% of cases. Some have postulated that this will actually be the dominant virus type circulating in the United States soon. Another variant is what's called the South African variant, and this is the B.1.351 variant. And then there's also a Brazil variant called P1. All of these have various changes in their genetic makeup of the virus that results in a change in the spike protein, the S protein, that is the major component that causes disease with COVID, and is also the component that vaccines recognize. The concern is that these variants seem to spread more quickly. For the UK variant, up to 50% more transmissible. And the UK variant actually seems to be associated with an increased risk of death. So far, however, studies suggest that antibodies generated through vaccination to the 3 vaccines available in the US recognize these variants. There is some concern for possible decreased vaccine efficacy with some variants, but again, I would highlight that the clinical studies shown nearly 100% efficacy at preventing the important outcomes of hospitalization and death. At the same time, we really have an urgent need to continue to follow our public health recommendations so that we can decrease the number of new cases, to decrease the opportunity for these new variants to emerge. Next slide, please. So I wanted to end with some thoughts on what we might expect in the future. I don't have a crystal ball, but I don't think that vaccines will offer an overnight solution. Herd immunity is expected to require 75 to 80% vaccination rates. And how fast we get there depends upon vaccine production, access, and acceptance by the general population. For fully vaccinated people, serious illness from COVID vaccine appears to be extremely rare. And the hope for the future is that COVID vaccines, while they may not eliminate risk, have the promise to turn COVID into the kind of risk that we accept every day. We may need to have booster vaccinations to address new variants or waning immunity, and we'll know more about this in time. Next slide. While we need to keep our foot on the brakes by continuing with masks and social distancing a while longer, there's good news that people who are fully vaccinated can start to do some of the things they stopped doing because of the pandemic. For instance, fully vaccinated people can visit other fully vaccinated people indoors without wearing masks or physical distancing. They can choose to visit with unvaccinated people from one household who are all at low risk for severe COVID disease, and they can do that indoors without wearing masks or physical distancing. And if a fully vaccinated person has had a known exposure, they can refrain from quarantine and testing if they remain asymptomatic. And for now, however, fully vaccinated people should continue to take precautions in public. So they should wear well-fitted masks and physical distance in public. They should continue to wear masks and practice physical distancing if they are visiting unvaccinated people who are at increased risk for severe disease, or who have someone in their household who is at increased risk for severe disease. And they should avoid medium and large-sized in-person gatherings. If they experience COVID symptoms, you should get tested, and you need to continue to follow any guidance issued by your individual employer, as well as following CDC and health department travel requirements and recommendations. But next slide, please. The future is really optimistic. For now, we should continue to mask up. We should socially distance and wash our hands. You should get vaccinated with the first vaccine that is available to you when it's your turn. And I'll end with our statement here, the team, and go blue. Thank you.
On our well-awares and offering some reflections with us. And I know we're all trying to stay optimistic here. And hi again to everybody who's still with us. I'm Ed Bottomley. I'm a frequent moderator for these well-awares with Michigan Medicine. And I would like at this point to invite all of our panelists back to the stage, the virtual stage. I'd also like to note that at this time, our panelists cannot give personal patient recommendations. They can give generalized medical advice, but not that personal patient recommendation. We're also going to dive into the Q&A portion of today's webinar, and we're going to start by taking a few questions that were asked pre-event, followed by our live Q&A using the Q&A Zoom feature. So I'll give just a moment for everybody to get back with us. The first question that we have for our three panelists: is there evidence shows COVID-19 can be transmitted post-vaccination? And I'll pass that to Dr. Malani first off.
Yep. Thank you, Ed. And I'm going to definitely call for, phone a friend here with Dr. Washer, because, with COVID, what I know in the morning changes in the afternoon. And I would say that we don't fully know the answer to this. And this is why some of the recommendations around fully vaccinated people are still saying you need to be careful, especially when you're with larger groups and if you're with people that aren't vaccinated. But this is unknown. One of the concerns is that you might be able to still transmit, but so far the data are looking optimistic. And I don't know, Dr. Washer, if you have more information on that.
Right. Well, I think what we're learning now is that there are persons who are getting COVID, symptomatic COVID infection even after vaccination. In those cases, those patients aren't getting very sick, but they do have viable virus in their nose, perhaps in their lungs. And although it may be at a much lower level than we see with unvaccinated people, it's still there. And that's really why we're concerned about the possibility for a vaccinated person to transmit disease. I think that there are ongoing studies by all of the vaccine manufacturers to really look at how much asymptomatic carriage or infection there may be. And the epidemiology will tell us, we'll learn over time, really in the real world, how many people who are vaccinated are getting symptomatic disease, how many of their contacts are getting infected. And that's really going to tell us a lot more. So we do still, as Dr. Malani said, have to be very cautious. We can start to make some kind of put our feet into dip our toes into the pool with some very specific interactions with fully vaccinated populations. But I think this is going to change over time. We're going to learn more in the near future.
Both for that. And I'll pass this next question to you, Dr. Washer. First of all, although I welcome contributions for all three of you. This one reads, how long should someone wait to get vaccinated after they have had COVID-19?
Right. So that's a really good question. The recommendation is that an individual can choose to get vaccinated as soon as 10 days after they tested positive for COVID, as long as their symptoms have resolved. Some have also suggested, however, that because the immunity, you expect to have some immunity from infection, that you may choose to wait a bit longer. I think at this point, given the availability of vaccines, as well as the uncertainty about variants, I would encourage people who've had COVID to just go ahead and get vaccinated when a vaccine is available for them, as long as they're kind of through the immediate symptomatic phase, no longer contagious to others.
The next question that we have on our list in the Q&A section, what data is available on the very first people in the COVID-19 vaccine clinical trials? Are there clinical trials and/or research happening at Michigan Medicine around people with long-term side effects of COVID-19? And I'll push that first off to Dr. Malani.
No, the early trials that got the emergency use authorization, so the Pfizer, Moderna, the Janssen or Johnson & Johnson, and then of course there's some that are ongoing. The current monitoring of those early patients, those participants in the trials, would mostly be around safety. And there's not a way, when you have tens of thousands of people all over the country to do ongoing testing. And what Dr. Washer said is important, where you're interested in symptomatic infection, but what we're not doing is systematically testing everyone every week to see if they develop asymptomatic infection. And that's a separate study that is going to be done on some college campuses, but not ours. We did consider doing it, but it's a little bit too resource intensive. So safety wise, there is ongoing monitoring. And so far, all of that is looking very good. I have to say that vaccines, the more and more we learn, the better and better they look in terms of safety. I know the three physicians on this call, I know we've all been vaccinated. My family's been vaccinated. I recommend it, just like Dr. Washer. And I also want us to not think of it as just protecting us, but as protecting everyone around us. I know there's some people that are waiting and they're waiting their turn anxiously, and you'll get there and it's going to happen. It's happening fast. The other question, Ed, is a good one, which is what kind of studies we're doing at Michigan Medicine. And this is also continuing to evolve. We were part of the AstraZeneca trial. We were part of Janssen, which is the Johnson & Johnson study. According to Dr. Dan Call, who I know has been on Well Aware, and many of you know him, is that we're hoping to be part of the adolescent arms of these studies in coming months. And again, it can change quickly. For people who are interested in research, that's wonderful. You can sign up on the portal, and depending on what your interests are, you get emails. I'm actually signed up on it, so I get emails every few days too about studies.
Yeah, and can I follow up on that, Dr. Malani? One of the things that I heard that you said that I liked a lot is protecting us all. Both of the initial trials, 10% of the participants were Black, and there were other underrepresented minorities. And it's important that when we talk about protecting all of us, that we think about all communities, including marginalized communities. And those studies, there was equal safety for underrepresented individuals. And I also, I know that there's been a long history of underrepresented individuals having hesitancy about being part of trials because of Tuskegee and the lack of trust with the healthcare system. However, if you are interested, we value people from all backgrounds to participate in these studies because we need to see how it might impact people of multiple different identities. So thank you very much.
I just wanted to follow up. Those trials were purposely made very representative, not just by race, ethnicity, community, but also by age. And I'm a geriatrician as well as an infectious disease doctor. And I'm really pleased to know that, 90-year-olds were in those trials, 80-year-olds were in those trials. And it makes it that much more important for all of us to participate in studies also.
I think Ed had asked also about the long COVID or the long-term effects of COVID and whether there are individuals doing work on that. To my understanding, there are a couple of clinics that have been opened at Michigan Medicine. One is for post-ICU care through the pulmonary clinic, and another is more of a multidisciplinary care that's being led by our endocrinology colleagues that has many members of other disciplines like physical medicine, infectious diseases, and others. And I'm certain that they are hoping to do some longitudinal research to help understand some of these populations and what what we can all expect from COVID for a long term.
So the next question that we have up actually, I think it's for you, Dr. Brown. How can we improve disparities of who receives the COVID-19 vaccine?
Yeah, so this has been talked about a lot nationally and locally. I know that our current administration has a social vulnerability index, which looks at areas of more social vulnerable individuals, which would hopefully capture underrepresented individuals. However, you might live in a county that averages out to have not such a low social vulnerability index, yet there may be hotspots within there by zip code. And so we need to identify those areas and target those areas to make sure that we are able to get vaccines to them. Another issue, and we have the data from the state of Michigan, is just having people trust that the vaccine is safe. When the state of Michigan did some research asking individuals if they're going to take the vaccine, Caucasians were more likely than underrepresented Black and Latino individuals. So we're doing a lot of messaging and partnering with our communities and working with community leaders to demonstrate that the vaccine is safe and that it's important for all of us to take. So I think it needs to be targeted, and also we need to work with our communities to increase the vaccination rates.
And can I just follow up on that? One of the National Poll on Healthy Aging, which I direct and sponsored by Michigan Medicine, we've been polling on this issue, and in October to January, we did see numbers go up across the board. I mean, they're still not where we want to be in terms of interest in vaccine, but I do think that we are seeing improvement in some of the hesitancy, and some people who are sort of, they wait and see, are moving to the I want to get vaccinated group. And they're also having conversations with their families. One of the things that's been really interesting, and I know we have a diverse group that listens in on these, is that the recommendation of people's doctors mattered a lot to them. And I think it gets at the issue of access and whether people even have a doctor or a routine doctor or a doctor they feel close with. And, talking, and I know Dr. Washer used to be a primary care doctor in her previous, before she came to do infectious disease. Those conversations take time. They take a lot of energy, but I know that a couple of my friends have had those kind of conversations lately. And so if you have family members who are a little hesitant, remind them to talk to doctors. And I also think hesitancy is not always about fear of safety. It could be technology issues. People are not on the portal equally. And this is older adults too. People share an email address with their spouse, and then they get kicked out of the system. So we really need to make it friendly in terms of accessibility, have good hours, physical accessibility, good location. And you know what? Some people are afraid of needles. And I think that's a different issue also. So all of those things, asking why people are hesitant and then trying to address it in an individualized way.
Thank you all three for those answers there. The next question that I have up, it's the cultural norm for citizens of some countries to wear masks voluntarily during cold and flu season. After we get through the pandemic, do you think mask wearing will become part of the US public health approach during the cold and flu season? And I'll pass that first off to Dr. Washer.
Right. So I think this is interesting because I think there's a science-based answer to this, and then a cultural-based answer as well. I think the science is really telling us a lot about the utility of mask wearing. In the past, we really thought about kind of covering our cough, right? When we're sick, we shouldn't be coughing on other people. And in the healthcare system, we've asked people to sometimes wear a mask in that setting. But really, in the United States, we've really never broadly worn masks when we're well. And so that's the difference. And so I think that I think that we're going to see a long tail to the mask wearing, in that until there's very little circulating COVID and until we get to herd immunity, many of us are going to continue to wear masks, even when we're well. The question is, should we be doing the same thing for flu season? And I think that there's some utility in thinking about that, and it really depends on how much flu is circulating, how much vaccination is going on, and how severe the flu is, or how at risk you are. And so I think that it will become, I don't know that it'll be the norm, but I think it may be accepted that certain individuals will choose to wear masks. I think to have a cultural shift where the US is like other countries where it is easy to see people wearing masks even 2 years ago. Whether that happens or not, I think, time will tell. So.
Thank you for that. The next question that we have up, how have social vulnerabilities affected the COVID-19 pandemic? And let's push that to Dr. Brown first off.
Yeah. So first, I want to go back to the last question as well that Dr. Washer answered as well, is that, I'm just hoping that our culture changes just in general, that we don't go to work when we're not well. Especially in medicine, we would work through illness, and I imagine other people do as well. And so I hope that we realize that when we're not well, we should take care of ourselves and we should protect ourselves from others. And maybe that would mean wearing a mask. Maybe that would mean social distancing. Maybe that would mean staying at home. And so I think can you repeat the question again, Ed?
Yeah, of course. This one, how have social vulnerabilities affected the COVID-19 pandemic?
Yeah, and so some of the challenges is making sure that we get vaccines to those who are socially vulnerable, and making sure that the people with more privileges, meaning or more access, more better transportation, don't get the access to them beforehand. So it gets back to kind of targeting individuals who are at higher risk from getting sick and making sure that we are able to get them the vaccine. And some of the challenges initially may be that, we were giving our vaccine on our campus. Sometimes it's hard to get here. Sometimes we need to go to those individuals who might not have transportation or the time to get here, or be able to get on the intranet, like Dr. Malani was talking about, having technology issues. So I think that those socially vulnerable indices should direct us toward individuals and groups who we need to target to get the vaccine to.
Thank you for that. The next question that we have up, and this is one that I've seen personally quite a lot of people ask: how long will the vaccine be effective? And do we anticipate this becoming a yearly vaccine, perhaps like flu shot? And I'll pass that first to Dr. Washer.
Right. So often vaccines information is gathered over time. So when we first had, for instance, the measles, mumps, and rubella vaccine to protect against measles, it was a one-time shot. And now we give that as a booster shot as kids enter school because it was found that it didn't remain protective through lifetime, and it required that booster shot. So the question about the COVID pandemic and vaccine is a bit more complicated because this is a brand new type of virus, or at least a virus that's causing disease at this level. It's a bit more complicated, but there's a question about how long our immunity lasts and whether we need a booster shot because our immunity falls, or do we need a booster because there's a new variant? And so I think that the first question is maybe easier to answer. There are a lot of people studying how long antibodies last and whether they last at levels high enough to provide protection. And in fact, researchers for the School of Public Health and at Michigan Medicine are studying those trends in antibodies among healthcare workers who have either been infected or vaccinated. And so we should get some more information about that from our own population. Whether the variants are going to introduce a need for a booster, I think is really still a very open question. And the question is, would that booster look different somehow? Would it target slightly different sequences or slightly different types of the S protein? And I think that question is still out there, but it's also potentially highly likely. So I would say more likely than not, I would expect that we might need to get a booster. I don't know whether this is going to be for a period of time, a few years, or whether it's going to be forever, like influenza vaccine. I think that there are many who think that the COVID-19 version of this is going to last for a while, and then maybe some other type of coronavirus. It may be more like a common cold for a while after we're all immune. So I think at least for the next little while, the likelihood of a booster is relatively high. I don't know, Preeti, what do you think?
Yeah, I agree. And I think the issue is the variance. And part of it is that when we look at immunity in the lab, we're looking at one type of immunity. Mm-hmm. In the body, there's many other types. And that if anything, your body can probably do a better job than what we can see in the lab. There's other correlates of immunity. So I'm hopeful, but I am kind of expecting to get a booster in the next year of some type. if I had to make a bet.
Thank you both for that. The next question that we have up after this one, as our systems, policies, and procedures change due to COVID-19, how do we help people navigate these changes and also offer equitable guidance? And I'll give that to you, Dr. Malani.
Thanks, Ed. This has actually been happening. And when I talk about change, even from the morning to the afternoon, things change. And it really is impossible. And I think that equitable guidance is really important. What I would say is that my best friends the past year haven't been Laraine and David, have been the communications folks, because of all the different things we've had to roll out across campus. And our communications teams, both at Michigan Medicine, on campus, in all the various units, they've been very, very busy, thoughtfully trying to put information, not just in written form, but verbal form, in signage, all over. And to kind of keep doing that and stay on top of it is a full-time job. I will say too, our public health agencies, whether the CDC, Washington County Health Department, Michigan Department of Health and Human Services, they have tried very hard to have information at appropriate levels for all types of health literacy levels, different languages, culturally appropriate. But this is an issue, and again, I think it gets back at those of us in healthcare trying to offer anticipatory guidance. And I think, again, focusing on the facts, the data, being transparent with it.
Yeah, can you hear me?
I can hear you.
I'm calling on the phone. I was having some Zoom issues. But one of the things that we're doing to ensure equity as well is that we're having representatives on a lot of the teams from representing equitable and diverse viewpoints. We need to be able to hear from each constituent group and what their concerns are, so that we can make sure that they are being advocated for. So for example, with the vaccine distribution, we had individuals who were looking out for equitable distribution of the vaccines. And so that was really important to ensure that we this out the best way possible.
Thank you for that, Dr. Brown. I know we have some live questions now that have come in as well. The next one that we have up reads, what type of interaction can you have with others once you are vaccinated? And does it matter if those you interact with have also been vaccinated?
Right. So hopefully we're going to get both a public health benefit and an individual benefit to be vaccinated. The whole goal of this mass vaccination strategy is really public health, but in order to incentivize us all to want to get vaccinated, we want to have some assurity that we're not going to get sick, and maybe that we're not going to get others sick. And so in your private life, if you have been vaccinated and the person you're going to visit has been vaccinated, you're good to go. You can, as long as you're not having symptoms, you can interact with that person in any way that you would have before the pandemic. If, however, you are going to be with an individual who is not vaccinated, you need to be a little more careful. And a lot of this is because we don't know exactly whether you might be asymptomatic and infected, or whether you might be able to transmit illness to others. So if you are vaccinated and you're going in your private life to visit or with somebody who's not vaccinated, that's okay, as long as that person is relatively healthy and not at high risk for severe outcomes from COVID. And or their family members, those that they live with directly, aren't. And really the goal here is to protect someone from getting really ill with COVID. And I think that those are the starting points. I think that we're going to start to see a little bit more, outside of our private interactions come out from the CDC telling us what's real to do. What if I'm, in a workplace where everyone's vaccinated? What can I do there, et cetera? And I think that right now we're kind of holding steady, holding the course. We don't have quite enough information to make us feel comfortable completely giving up on social distancing and masking there. But I think that we're going to see inching forward more liberties being recommended. And as more people get vaccinated, those opportunities are going to increase. From a personal perspective, my parents who meet the criteria for vaccination based upon age will be getting their second vaccine next week. And 2 weeks after that, I'm going to feel great going there to visit them. I'm vaccinated, they're vaccinated. I'm going to give them both a really big hug and feel like we've accomplished something. So.
Thank you very much for that, Dr. Washer. What are your thoughts on single versus double masking?
I can weigh in on it quickly.
Yeah,
and I've spoken with Dr. Washer about this. I am, masks are one, all of these are layers: vaccination, masks, distancing. And, you layer these things in order to keep yourself as safe as possible, everyone else. And, my focus has been a good quality mask, something that is not too thin. It has multiple layers, but that fits well, it's comfortable, and it covers your mouth and nose properly. If you want a double mask, that's okay. But if you're sitting in a classroom all day, for example, or you're at work all day, it might become a little bit uncomfortable. So comfort is important, and proper mask usage. Now, it's very different for us in the health system and the kind of masks we need to use. But for your day-to-day life, that distancing and not being in a crowd is just as important.
I muted myself before I could throw in the next question. Let's try and do one more live question, and then we have our final question after that. Next question reads, do we have any data on how effective the Moderna and Pfizer vaccines are against the new strains?
Yeah, I can't tell. I think we are getting some data on that. And I think that the first level of data that we're getting from Pfizer and Moderna is those antibody measurements that Dr. Malani mentioned. And in general, the levels of antibodies, neutralizing antibodies against the new strains, particularly the South African strain, are a bit lower than against sort of the wild type strain that's circulating, but they're still really high. And the expectation is that they're going to be as effective at preventing serious illness and those that cause hospitalizations or death, even with these new strains. And in fact, Israel has been very effective at vaccinating their population. And they have had a lot of the B117 vaccine or variant in Israel. And they're seeing these vaccines being really effective. And so those are the two pieces of evidence that we can see regarding that. And with regards to the Johnson & Johnson vaccine, there's a little bit reported decreased efficacy when tested in a population where there was a lot of the South African variant, the 5.1 variant, but really only decreased efficacy in symptomatic disease, still nearly 100% efficacy at preventing hospitalizations and preventing deaths from COVID. So I think that's the data that we have. So I'm very optimistic that if we can get the population vaccinated at a high level and we can do it quickly, if we can outpace these variants, we'll be successful.
Thank you so much. And let's swiftly move into our final question, which I want to make sure I get to, and it's delivered to all of you. How likely is another pandemic to occur again in the near future? And what are Michigan Medicine's plans to help combat one?
I would say that it's likely because it happened 100 years ago. It happened between that, so not at this level. My hope is that we'll be better prepared. Some of the major shifts and transformation that have happened would hopefully prevent it from becoming truly pandemic and the kind of devastation that's happened. But with the number of people that live in the world and the way we live and the density and how we live among humans and animals and our interactions, it is unfortunately likely. Hopefully it'll be after I'm retired, though.
Anything to add, Dr. Brown?
I'll just add that we have some really important opportunities to look at our healthcare infrastructure with caring for emerging diseases as we build our new tower. as we do renovations. I think these are some of the very structural preparations that we'll do, and we'll lay those on a lot of the pandemic planning that we've done. And we've been planning for a respiratory virus pandemic for a long time. And the next pandemic may be a variant influenza, or maybe it's going to be another coronavirus, or maybe it's going to be something else. I think it's inevitable that we're going to have another pandemic, but I too hope that this is the pandemic for our lifetime, and that we continue to invest in science so that we can have really good solutions like vaccines that come on board very quickly to really limit impact.
And briefly, I just hope that we're building trust and building healthy communities of all backgrounds, so that if we do have another pandemic, we become a trusted source of information, and that the people are as healthy as possible to survive the next pandemic.
Thank you. Thank you, all three of you, for your expertise here. Dr. Washer, Dr. Malani, Dr. Brown, thank you very much. And if you enjoyed today's topic, please join us for the Department of Internal Medicine series, which is next month, well aware, on Thursday, April 29th from 12 to 1 p.m, where we'll discuss post-COVID care and health disparities within COVID. And the RSVP link will be put in our chat. And before we conclude today's webinar, I'd like to welcome Jennifer Edwards, Senior Director of Development for Michigan Medicine Development. Jennifer?
Great, thank you so much, Ed. Thank you to all of our panelists for offering your valuable time and expertise this afternoon. Each of you has been with us on more than one occasion, helping us navigate this pandemic, and we're so very grateful. I want to thank all of our attendees for your engagement and interest. We hope you found the session informative and inspiring. Your questions were great. We tried to get through as many as we could, and we welcome future engagement with those of you who would like to learn more. My sincere thanks to our wonderful donor community who has joined us here today. We are grateful for the ways in which you have lifted us up over the past year, particularly last spring with the outpouring of support for our frontline caregivers with meals, PPE, and support for the COVID relief efforts. Those kindness and connection helped provided much needed inspiration during a very difficult time. As we heard today, the work continues to get us through this pandemic and in caring for all of our patients. I want to remind everyone that a recording of the webinar will be sent in a follow-up email to those of you who registered, along with links to our Discovery Research Fund and the Office for Health Equity and Inclusion Fund. We hope you'll consider contributing to the important efforts as our faculty and staff work harder than ever to live out our values of caring, innovation, equity, and inclusion, to advance health, to serve Michigan and the world. There will also be videos of today's webinar posted to both our Michigan Facebook page and YouTube page. Please join us for our next Well-Aware webinar, The Impact of Telehealth and the Patient Experience, on April 8th at 1 p.m. Our experts will discuss telehealth, which has served as a vital link between healthcare providers and patients during the pandemic. We'll hear about lessons learned that will shape the future and what elements of telehealth we can expect to remain once the pandemic is over. Thank you again so much for joining us today. Please stay healthy and safe. Thanks, and go Blue.